Part 2 of heart failure, cardiomyopathy, and other disorders. We're into the other disorders. I need to move ahead to slide 20 to carotid artery disease. Carotid artery disease, you need to keep in mind that brain damage occurs after 4 to 6 minutes. The usual cause of carotid artery disease is atherosclerosis. Symptoms are those of a neurological deficit. If they have a TIA, it lasts less than 24 hours, no permanent damage. RIND is a reversible ischemic neurological deficit, the symptoms of which can last up to 6 weeks, usually less than 72, but it can last up to 6 weeks. Stroke, symptoms are there for over 72 hours. You'll have some permanent damage. Treatment, you need to decrease the risk factors, give them antiplatelets, do an endarterectomy. You'll find collaborative treatment. Nursing, you'll be doing neuroassessments and a lot of patient teaching, among other things. You'll find your patient teaching and your nursing diagnoses on page 487. DVT will lead to pulmonary embolism if it is left untreated. Virchow's triad, your venous stasis, hypercoagulability, and endothelial damage or injury is what causes deep vein thrombosis. This is diagnosed by ultrasound. To evaluate patency, a D-dimer blood test will increase with blood clot formation. Normal is less than 100. Your VQ scan will show any emboli that have gone to the lungs. CT of the chest may also show that. Symptoms are pain. Oftentimes a positive Hohmann sign, as I mentioned earlier, it may not occur. Redness with swelling, mottling with cyanosis, and warmth. Treatment, preventive, prophylaxis, then pain management, bed rest, anticoagulants, anti-M hose, and EPC cuffs. My mom, after my dad died, sat in a chair. I would come home from work and she'd be in a chair. I'd get up during the night and she'd be in a chair. I'd get up in the morning and she'd be in a chair because the bed was too big. They'd been married over 48 years and it was just too big. Now she would change clothes and get up and about, but she just wasn't doing well. So I decided she needed to go away. So I took her to Frankenmuth, Michigan, and if you've never been there, it's kind of hilly. And I walked her up one hill and down another. And when we came home, because we were there for 3 days, when we came home on Sunday, because I had school on Monday, she woke up about 2 in the morning and said, "Julia, I'm going to die." And I said, "I'll call 911. And she said, "No." And I said, "Yeah, if you're going to die, I want somebody here." She said, "No, but I'll go to your hospital." So at that time I was working at Riverside. It's not my fault it closed. That happened after I left. And I had to drive her at 3 in the morning to Riverside Hospital, the emergency room. At 3 in the morning, I don't think there were any police on the highway. I couldn't find a single one. But I got there in half the time it normally took me. And I knew the ER doc, and I explained what was going on. I thought she was just basically deconditioned because I felt good pulses. She had a negative Hohmann's, and her lungs sounded okay. Well, he agreed with that, but he thought we should probably get some blood gases. And on her blood gases, she had a PaO2. Now, my mother never smoked in her life. Had a PaO2 of 54%. And she was on supplemental O2 at 2 liters at the time. And he said, "I think she's right. We're going to keep her. She probably has a pulmonary embolism. We'll order a VQ scan." And she had that, and it showed multiple emboli scattered throughout all of her lungs. They did Doppler studies of her legs, and they found a huge clot behind her right knee. She was in the acute coronary care unit for 72 hours. She was in the hospital for 6 or 7 days, I don't remember which, and she was on Coumadin for 6 months. When she came home, she set her alarm. So every 2 hours, she was up walking somewhere. She never wanted to go through that again, and she never had to go through that again, for which we were very thankful. 90% of patients who develop pulmonary embolism get it because of a deep vein thrombosis, and that is why she got it. Page 490 shows your collaborative treatment. 489 lists your nursing diagnoses, and 490 also has your patient education information for this. Hypertensive crisis can occur if you have somebody who has renal failure, acute central nervous system event like a hemorrhage, drugs, particularly coke and speed, can cause it. The cheese effect from your tyramines with your MAO inhibitors, like if you're on an MAOI and you're drinking beer or aged cheese or the pepperoni. Eclampsia and pheochromocytoma, which is a tumor of your adrenal medulla, which would secrete a large amount of catecholamines. All those can cause hypertensive crisis. Your symptoms: you'll have central nervous system compromise, so you'll have a headache, blurred vision. Papilledema will show up if you have an increase in intracranial pressure. Seizures or a change in level of consciousness. Cardiovascular compromise: you might have acute coronary syndrome or aortic dissection. Acute renal failure will give you a decrease in urinary output, and your catecholamine excess again will give you your hypertension. There's a table on page 491 that lists all the possible causes. Not all of them, but most of the possible causes. Treatment: nitroprusside, which is nipride, and you have to protect it from the light, and it has to be on a pump. Nitroglycerin, which has to be in a glass bottle and run separately. Nothing else can go with it. Your beta blockers, like labetalol or esmolol. Remember, your beta blockers, ON and OL. And you want to make sure that it is a selective beta blocker if they have any respiratory disease. Non-selective will cause bronchospasm and will prevent them from breathing appropriately. ACE inhibitors such as enalapril or Vasotec IV. Your loop diuretics will help. If your patient's in renal compromise, instead of enalapril, you'll want to give phenoldipan, which is a dopamine receptor antagonist, to lower the blood pressure and increase the renal blood flow. If they have eclampsia, you're going to give hydralazine, and you're going to give nicardipine, which is a calcium channel blocker, if they have central nervous system compromise. You want their mean arterial pressure to be, you need to lower that about 20% during the first 24 hours. And if you do more than 20%, you're going to have neurological problems because you're going to have rebound in their intracranial pressure, and it's going to cause some more problems. 493 in your textbook has the treatment, and if you don't control that blood pressure long term, there'll be a 50% mortality. Your nursing diagnoses are on page 492, and your evidence-based practices on page 493. Temporary pacemakers are put in to maintain a base heart rate. They can also be done for overdrive pacing. Now, overdrive pacing is to go over somebody's base heart rate who's already tachycardic and try and slow it down. Your pacing routes can be transcutaneous, which is through the skin, transthoracic, which is directly through the chest wall, epicardial, which is where it's screwed onto the heart muscle. That's usually done after surgery, or transvenous. Now, it's usually, the wire that goes in is usually bipolar, in case one breaks, but it can be unipolar. Unipolar is more sensitive to extraneous signals like IV pumps and muscle movement, so that's another reason they tend to use the bipolar leads. Your epicardial, as I said, is used after surgery because you've got the chest open and you can just screw it in where it needs to go. But you need to make sure you have somebody who knows what they're doing, because if they screw it through a coronary artery, they've just caused a heart attack. There is a box on page 499 for your indications and for your components of your temporary bipolar pacing catheters. On page 502, you'll find your external generators, a picture of them. Pacing codes identify the chamber paced, the chamber that's sensed. Those codes would be either 0 meaning none, A the atrium, V the ventricle, D whether if it's both or dual, T whether it's triggered, this has to do with your response to sensing, or I whether it's inhibited. It's programmability. Is it single programmability, your rate, your output, your sensitivity? Or is it M? It means it's multiple programmability. C means communicating and R means rate responsive. Anti-tachy dysrhythmic function means that it provides pacing and shock. So this would be somebody who had an implantable cardioverter defibrillator pacemaker. And there is a table on page 501 that lists all that lovely code data. Temporary pacemaker controls, you'll have your threshold, which is the point at which capture is attained or achieved. Your milliamperage, which is usually 2 to 3 times that of the threshold. The millivolt, which is your sensitivity, that's usually half of the threshold. Your AV interval, which is your PR interval, and your rate. If you have a temporary pacemaker, you want to mount that generator on an IV pole using a bridge cable. And you're going to cover with a rubber glove all the connections because this needs to prevent the microshock. You want to prevent the infection, so you're going to have a sterile dressing over the insertion site. And you'll change that according to hospital protocol. You want to check that underlying rhythm every shift. And it's very easy to do. You just push a button on the monitor, hold it in so that the pacemaker doesn't function. You don't turn it off. If you see nothing in one screen across, that's long enough to say it's not going to, they don't have an underlying rhythm yet. Take your finger off the generator. You need to assess for any pacing abnormalities, such as failure to sense or failure to pace. And there are examples of malfunction on page 505. There are rhythm strips that show the pacemaker spike on page 504. You need to label the generator when the battery was inserted. Most batteries are good for a month. There's a box on page 506 that lists the nursing diagnoses, and 507 for the patient education. Permanent pacemakers can also have an automatic implantable cardioverter defibrillator with them. There's a picture on page 507 that shows the size of a permanent pacemaker. And on 509, there's a figure for AICD placement. They're used for ventricular fibrillation or ventricular tachycardia, known coronary artery disease, or a heart attack. Left ventricular dysfunction with VTAC and VFib on EPS studies is another indication for a permanent pacemaker, or somebody who's having sinus pauses. The codes are on page 507. The nursing diagnoses are on page 510, and your patient teaching is also on page 510. Fibrinolytic therapy is best used within the 6 hours of onset, but up to 24 hours after you can still get some benefit from a fibrinolytic. If you're talking cerebral, 3 hours is the limit, although there was a recent research study that said you could go to 4 hours and still get some benefit without any problems. Those patients that are eligible for fibrinolytics are patients who have recent chest pain with ST segment elevation and 2 or more leads, IVCD which is intraventricular conduction delay or bundle branch block, and a history of a heart attack with chest pain, or somebody who has chest pain that's unresponsive to nitroglycerin or nifedipine. There's a figure on page 511 that shows the clotting cascade and the drugs that impact on that clotting cascade. You should look at that. Different types of fibrinolytics. Streptokinase, it's the oldest. These are listed on page 512. It is not clot specific. Now, when something is said it's clot specific, it means that the drug targets the plasminogen of the formed clot, converting it to plasmin, which dissolves the clot, not the plasminogen, which is circulating. So streptokinase will dissolve everything. It's given by IV drip. Another form is APSAC. It has a longer half-life. It is also an IV drip. The problem with streptokinase, you can develop an anaphylactic reaction if you ever have to take it again. So you usually only get it once. TPA, T-Encase, That should be our TPA, which is Retaplace, is clot specific. These are all based on genetics. Your TPA is Alteplase. It is an IV drip. TNCase or Tenecteplase is a single bolus, and our TPA is a Retaplase. This is 2 IV boluses. The thing with any of these clot-specific drugs is that they can be repeated as needed, which is a benefit to the patient. You want to administer aspirin a day. 81 milligrams is sufficient unless they're a diabetic, and then they're recommending 325. Heparin drip for 24 to 72 hours. Reperfusion occurs when their pain's gone, when they get a dysrhythmia, or when they have what's called a CK washout, which means that their CK values will rise rapidly over 6 hours rather than trend the way that they're supposed to. There's a box on page 514 that shows the symptoms of reperfusion. Your nursing diagnoses are on 514 and patient education on page 515. PTCA, there's a picture of the procedure on 515. It was first done in 1977. There's a 520, shows a picture of the results of somebody who's had a PTCA. Aspirin or glycoprotein 2B3A inhibitors are given. There's a table on 519 to 520. An atherectomy can also be done. There's a picture of that on page 516. They can use a laser to dissolve the clot and then suck up the pieces. Stents, there's a picture on page 518. And of course the bypass graft surgery. The glycoprotein 2B3A inhibitors are drugs like abciximab or Repro, Aggrastat, or Intelligrin. Your nursing diagnoses are on page 521. Patient education is on page 523. Your nursing care following a PTCA is to elevate the head of the bed about 30 degrees, apply pressure to the site, ambulate after 6 to 8 hours. There's a figure on page 522 that shows how the artery is sealed, and a table on 523 for the different types of closure devices. Usually they'll seal the site now with a VasoSeal or AngioSeal. You may also get a collagen plug. There's a table on page 523 for the different types of closure devices that might be used. Bypass surgery, there's a table on page 2010, page 528 for the physiologic effects of cardiopulmonary bypass, and a table on page 526 for the types of grafts that are used for bypass graft surgery, the advantages and disadvantages. Nursing care for cardiopulmonary support to increase preload. You want to do that with fluids, volume expanders, or packed red blood cells. You decrease afterload with nitroprusside. You control the heart rate with a pacemaker, beta blockers, or calcium channel blockers. There are figures on page 525, 4 diagrams of the bypass grafts. Your traditional bypass is still being done. Average day, 4 to 7 days. The minimally invasive coronary artery bypass graft, or not on the bypass pump, the hospital stay is shorter, uses special instruments and or a robot to perform the surgery. It's also called the keyhole surgery or the beating heart surgery. Revascularization surgery plows grooves into the ventricular wall to get the blood to the diseased myocardium. It can be done percutaneously, which would decrease complications like death. Evidence-based practice is on page 531. You want to increase that contractility, and to do that you may use an intra-aortic balloon pump. Temperature regulation, you're going to use warmed blankets. Take them off when the patient gets to 37 degrees centigrade. You want to control the bleeding. There's a page 530 for the medications that are used there. Autotransfusion, there's a figure on page 539. Your chest tube patency, milking versus stripping. You do not do either without a direct physician's orders because it causes problems. Pulmonary care, you need early extubation within 4 to 8 hours. Infection, If the temperature goes over 101 Fahrenheit or 38.3 centigrade, you will do a culture. Sorry for the pause. Your renal involvement, they'll give Lasix if their output drops below 25 milliliters per hour. Patient education is important. If they develop neurological complications, oftentimes it's called post-cardiotomy syndrome, you'll want to treat them with Haldol, get the family involved. That will help. The nursing diagnoses are on page 529. Valve surgery is a balloon valvotomy. This is a replacement surgery. The different types are on page 527, and that will also have a box on there for the classifications of your prosthetic cardiac valves. They can be biologic, which is porcine or a homograft from a cadaver. Mechanical, which is your caged ball, your Star Edwards. Your tilting disc, which is Medtronic, and your bileaflet, which is St. Jude's. Your mechanical valves, they need to be on anticoagulants forever, and they also will have an audible click that you can hear on occasion. So that's something that you need to look at. Ventricular assist devices, there are page 537 lists the different types of VADs. They can be used as a bridge to transplant. And there are only about 2,000 transplants a year. More people need them. They can be done pending recovery following a heart attack, myocarditis, or post-bypass surgery. They can also be done as a permanent support or destination therapy, and they're good for 2 to 3 years without any problems. They have been shown to decrease their heart failure from a New York Heart Association grade 4 to a 1 or a 2, 85% of the time. So they are very beneficial. There's a picture on page 538. There are different types. You've got your pulsatile, which is pneumonic or electric, and you've got your non-pulsatile, which is a roller, centrifuge, or axial flow type. Your nursing diagnoses are on page 538. Your biventricular assist is done if you have somebody who's a very sick person, because it'll do both your right and your left. The VAD does the pumping, so it's okay to have the patient in ventricular fibrillation, and oftentimes these patients are not actually on a monitor. The Thoratec HeartMate is approved for home use. There's no anticoagulation that's required, only antiplatelets, because it uses a porcine valve. It costs about $3,600 for a battery, and they need about 6. They have an average VAD costs about $70,000, and Medicare will cover some of that. The atrial implant does not require bypass pump in surgery. Now, peripheral vascular treatments, there's a figure on page 542 that shows the different types of bypasses, and one on 541 for the different types of grafts for a AAA procedure. This finishes this portion. We'll continue with cardiovascular meds in a bit.